Hello, my name is Gabrielle Carlson, and for my advanced assessment technique, I will be discussing percussion for borders and size measurement of the liver, as well as Murphy's sign. Uses for percussion for borders and size measurement of the liver. We would use this assessment technique to determine the location and the size of the liver in our assessment of a patient with concerns of hepatic disease. Potential diagnoses might include hepatitis, cirrhosis, liver lesions, liver cancer, and potentially liver masses. Our patient may be presenting with right upper quadrant pain, discomfort, fatigue, altered mental status. When doing lab work, we might find that they have an elevated ALT or AST, as well as elevated ammonia levels. To complete this assessment, I will refer to this photo that I have here on my PowerPoint to help easily look at the landmarks that we want to see. We will start with identifying the fifth intercostal space as well as the right costal margin. And in completing this assessment, we will go from the superior to inferior and then inferior to superior to percuss the liver. Specifically, we want to identify if there is a change from tympanic to a dull sound. Likely it'll start tympanic and then we'll go dull. And when we find this change, we want to note that and document to determine if there is liver enlargement. For percussion of borders and size of the liver, I will identify the fifth intercostal space on the patient. I'm just going to be feeling for your ribs.
Okay.
And this would be to the right of the umbilicus, just slightly above. I'll perform a percussion technique to identify changes from dullness and tympanic. It'll first start out tympanic and then go to dull when I identify where the liver is. So right there. Right there. So I will make sure that I document and identify exactly where the borders are. Specifically for my patient, I don't note any enlargement of their liver. Like I said, size is determined by the age and sex of the patient. And for my next The next advanced assessment skill that I will be doing is the Murphy's sign. This will be used in the acute event that a patient is presenting with right upper quadrant pain. Our patient may be ill appearing, having nausea, vomiting, as well as a lot of pain in that right upper quadrant. They may be experiencing signs of infection such as fever, they may be tachycardic, tachypnic, hypotensive. We may see an elevated white blood count. Our concern really is for cholecystitis. If we find that there is a positive Murphy's sign, cholecystitis is gallstones or an obstruction causing inflammation to that gallbladder. You can see in this photo here, we have the bile duct as bile is coming from the liver and going into the gallbladder and then out towards the pancreas. Sometimes it can be stored and form deposits and hardening, causing gallstones, and then when trying to move out, it can cause a blockage, whether in that full gallbladder or within the ducts. To complete this assessment, I will have my patient inhale, exhale. On that exhale, I will be palpating for the gallbladder. I will have them take a deep inhale, and if they experience that sharp shooting pain, that would be a positive Murphy's sign, and I would want to notify the provider to initiate some further testing, such as a CT of the abdomen and or an ultrasound. And for my next assessment, I would be completing Murphy's sign. This will be used to identify if a patient is having acute cholecystitis. What I'll first do is have my patient take an exhale while palpating on, similar to where I identified where the liver was. And then I will have them take a deep inhale, and I will press and palpate on that area. If they experience a sharp shooting pain, that would be a positive Murphy sign, which would mean that they would likely have acute cholecystitis, and I would want to advance the care to getting a CT or an ultrasound. If they aren't experiencing any pain, this likely would not be acute cholecystitis, but should not dismiss the possibility. So I will have my patient take an exhale. I'm going to be palpating this area, and then I'm going to ask you to take a deep inhale, and I'll be palpating here. Are you experiencing any sharp pain?
No.
So specifically in my patient, they do not have a positive Murphy sign, but if they continue to have pain, a CT or an ultrasound would not be wrong to complete. Thank you. I can also complete a typical abdominal assessment. First, I would start off with some questions. How is my patient feeling? Are they nauseous? Are they vomiting? Any constipation or diarrhea? Any indigestion or heartburn? Not just to the right upper quadrant, but I also want to know, are they having pain anywhere else in their abdomen? Are they passing gas? When was their last bowel movement? Especially with the bowel movements, I would like to know, what do their stool look like? Is it brown? Is it black, red? The color can really indicate if there is a GI bleed present. If it's frank red blood, that is a lower GI bleed that's closer to the end of the GI tract. If it's, black, tarry, it may be up further. In that case, we would want GI to be consulted to see if they can perform anything like an endoscope or a colonoscopy. I also want to know, aside from the color, what does the stool look like? Is it pebble-like? Is it loose liquid mucus? That liquid mucus means that, our body's not absorbing those nutrients, being able to, exchange fluid, and our patient may be malnourished at that point. I also want to know, what does their nutritional status look like? Do they intake any fiber, protein? Does their family have a personal does the patient or does their family have a personal history of GI conditions, cancer? Do they have ulcerative colitis? Do they have Crohn's? This can also help identify any kind of advanced conditions. And then one other thing that I'd like to know, do they have a use of laxatives or stool softeners? After asking my patients the questions, I will move into an inspection. I will have them lift up their shirt. I will see, is the abdomen round? Is it flat? When assessing if a patient has a round abdomen, I want to see, is it proportional to the rest of their body? Are they a patient with obesity, any anorexia, bulimia, any kind of that, which would be identifiable and help diagnose the patient. Is the belly distended? Are they having fluid or air trapped in that belly, causing it to look more round and obscured? Next, I will be completing auscultation. I'll be following with my stethoscope. I'm using the diaphragm, so this portion of the stethoscope. I will move from the right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. I would like to identify what kind of bowel sounds my patient is having. Are they normal active, which would include having bowel sounds 5 to 35 times a minute, or are they hypoactive? Are they having less than those 5 bowel sounds per minute. This could be a complication of having opioids, narcotics in the system, or experiencing anesthesia recently with surgical procedures. Our bowels have trouble kind of waking up from those things. Or are they hyperactive? What has the patient eaten recently that could, stimulate the bowels? Assessment would also move into percussion. As we saw in the assessment of percussion of borders, we want to identify tympanic versus dull sounds. Next, I will move to palpation. How does the abdomen feel? Is it firm? Is it tender? Is it soft? Is the patient experiencing any kind of pain or discomfort with me touching to their belly? And are they guarding? Are they, bracing themselves for potential palpation to areas that are tender, such as if our patient is experiencing appendicitis, they would definitely be guarding, as well as with cholecystitis, they would definitely be guarding their abdomen. Here are my references. Additional diagnostic tests that we can perform are ultrasounds. This would be helpful with our cholecystitis, being able to see, is bile passing through? What does the flow look like? Can we see those stones? We can also complete an CT of the abdomen and pelvis to identify any kind of enlargement, inflammation. We can also perform blood work that is indicative for inflammation and infection, such as white blood counts and a CRP. And lastly, eventually, if our patients wait too long to come and see us with this pain, they can have concerns for sepsis, like a perforated appendicitis. That infection can leak into the bloodstream, causing positive blood cultures and such. So we want to make sure our patients are educated and prompt in their seeking of medical care when they are experiencing these kinds of things. And then lastly, here are my references that I included for the included